Right. One of the well, we just finished respiratory failure and ARDS last week. Now, one question on the exam will be who will need to be intubated? Before we go into mechanical ventilation, let's discuss airway first because you need an artificial airway in order to put somebody on a ventilator. Okay, so the sequence usually is with, if you remember from fundamentals of nursing, so we have the lowest oxygen delivery will be the nasal cannula, correct? Then we move on to the simple mask, and then we have the Venturi mask, we have the partial rebreather, non-rebreather, and then if the patient still cannot improve oxygenation via those mechanisms, then we'll have to do BiPAP. BiPAP is the last positive pressure, non-invasive means of delivering oxygen. If they do not improve with BiPAP, such as in ARDS, for instance, respiratory failure, they may improve on BiPAP, but ARDS, because of the nature, the lungs are filled with water, so therefore they need to be intubated, okay? Because you need to put them on a mechanical ventilator. So that's just one indication. Other indications are, of course, we have respiratory failure, which there are two forms. We have oxygenation and then we have ventilatory oxygenation, respiratory failure. I explained the difference between the two. Really depends on what was the cause. Okay, what was the underlying condition that led to the state of respiratory failure. Other conditions are if we have someone undergoing surgery, a major surgery in which we need to give them general anesthesia. You cannot put somebody under general anesthesia without intubating them because they will get paralyzed. Okay. So because you give them on top of anesthesia, you give them muscle paralyzers, which will depress respirations and paralyze the diaphragm. Okay, so that's another indication. Another indication would be, of course, hypoxemic or oxygenation or ventilatory or hypercapnic respiratory failure, which includes someone who's been breathing, let's say, 40 times a minute for the last hour. How long can you sustain that? Try breathing 10 times every 15 seconds and let's see how long you'll stay alive. Okay, so we have to intubate those people. Okay, so that's something you need to consider when you're talking with your family about, let's say, the consequences of their advanced directives. Some people want DNR, DNI, nothing wrong with that. But some people have different qualifications which they don't understand. They will say, oh, no compressions, but intubate. Okay, so imagine the scenario in that. Okay, or let's say we have um, uh, chest compressions only, but no intubation, right? Because sometimes people don't understand what that looks like. Okay, so let's say we're doing chest compressions, but then you don't want to be intubated. How's that going to work? Can you imagine that scenario? Okay, so some people just need explanation, okay, before they sign something, okay, or before they choose those things on the MOLST, because this is what we have in New York State. We sign MOLST, okay, medical order for life-sustaining treatment, and there are specific choices there. So I think the best thing would be to modify the MOLST to not have those options available. Okay, because it doesn't look pretty. Okay. Anyway, yes. No, I'm just leading to that so that you appreciate intubation. Okay. 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 So now we've got endotracheal intubation. There's also oral nasal. Okay, for small children, for instance, you can do through the nose, but the most frequent is endotracheal. through the mouth down into your carina. So I explained in detail how to check position of the endotracheal tube, and also what we use to seal it. Okay, the methods we use to seal, because we need to make sure all the air comes in and out only through the tube. Because if we have any air leak, for instance, the patient is partially able to breathe through the nose, that doesn't make any sense. So if you're going to intubate somebody, then the tube must be solely the entry and exit of your air. Okay, so in order to accomplish that, two things. One is placement. So one of your duties, there are 5 responsibilities of a nurse when you're caring for someone with an artificial airway. One is, of course, verifying tube placement. We need to know it's in the right tube, because we have 2 tubes here. We have the esophagus and we have the trachea. Where do you want it? The trachea, right? Okay, so that's number 1. And there are 2 ways to do that. One is to, well, there are several, but the 2 most common ways to verify placement is end-tidal CO2 detection. That's the earliest, because the chest X-ray will confirm it. However, chest X-ray will take a few more minutes. Okay, unlike before, wherein we needed an X-ray film, now portable X-rays have digital screens, so the doctor can literally look at the screen and then check the verify placement that way. Okay, so we don't need to go downstairs, develop the film, and then give the film to the doctor to see. Okay, so they can see it right there on the portable X-ray screen. Does that make sense? Okay, so we can verify placement faster now. The end-tidal CO2 is a sensor you put at the tip right here, at the tip of the tube, in order to check the CO2 level. Of course, if the CO2 levels are high, where is the tube? Do we have a lot of CO2 coming from the stomach? Yes or no? No, because CO2 is expelled by the lungs. So therefore, if it's normal or high, it must be in the airway. Okay, it must be in the trachea. So that's just one placement. Other means, of course, if the chest is not rising, is the abdomen rising? Where is the tube? In the stomach. Okay. Can you also listen for lung sounds? Yes. So if you're bagging someone or if you're connecting them to the ventilator, what should you hear? Lung sounds, okay? Or either that's normal lung sounds or it's crackles, but any lung sound will verify that where is the tube? It must be in the airway, okay? Because otherwise you won't hear any lung sounds, correct? So that's one. Second responsibility is to maintain airway patency. Now, imagine the tube. So it's the same as when you put a lollipop or even a toothpick or a pencil in your mouth. What will it do? What will it stimulate? Secretions, correct? Okay, so since this thing is in your mouth, will it stimulate secretions? Will there be secretions in that tube? So how do you clear the, okay, suction. How often do we suction? Only as needed, okay? There's really no limit as to how many times, but what's your frequency based on? Is there a need, right? Because you said as needed. So how do you know the patient needs to be suctioned? Give me 4 indications. Audible or visible secretions. What else? Okay, abnormal lung sounds, particularly what lung sounds? Let me explain crackles. Crackles is in the alveoli, okay? You hear crackles with alveoli popping, especially if there's secretions in the alveoli. Look at the tube. Does the tube reach any alveoli? They are microscopic, so the tube only reaches where? The carina. So what will you hear? Bronchi, okay? Wheezing, okay? So large airway sounds. Are we clear? Okay, so don't say crackles. Crackles are in the alveoli, okay? That's not an indication for suctioning, because don't tell me your catheter will reach a microscopic section of your lung. It won't, right? Okay. So what else? What about the saturation? Yeah, that means oxygen is not going through the tube. Okay. What about the patient's mental status? Because remember, these patients are intubated. So if they're intubated, they must be sedated, correct? Okay. So which reminds me to another topic. Endotracheal intubation will only be for how long? How long can someone be on this tube? 2 weeks. Okay. So 10 to 14 days is your maximum. After that, obviously, if the patient still needs it, are they improving? No. The condition remains the same. There's so many complications of this type of therapy. So if the patient needs intubation for longer than 2 weeks, we will have to switch to a tracheostomy. Okay? Because with a tracheostomy, there's no need to sedate the patient. Do you understand? Okay? So it's better, right? Rather than endotracheal tube, because now you keep sedating the patient. Of course, you have so many complications there. If someone's sedated, they can't eat, they can't talk. Okay, you can't move them easily. So it's better if you put them on a trach. You can stop sedation. You can even sit them up. Okay, they can be on a chair. If they're strong enough, they can walk. All right. Okay, so we said verifying tube placement, maintaining airway patency. Next is to secure the tube. Now, there's no picture here, but I did show a picture of the commercial tube holders on the recording. So please refer to those. Another is ensuring proper cuff inflation. We need to there are two reasons why there is a cuff on the tube. One is, of course, is it used to secure the tube? Will a cuff like that secure the tube? Will that prevent me from pulling the tube? Not at all. Okay. Because will the cuff have like needles or arms that will anchor itself to the no. Okay, so it's not like it's a bladder. Okay, a balloon in a bladder would secure it, correct? Or so we hope. But this thing, is this really securing the tube? Not at all. What's it doing then? A seal, okay, providing a seal. Two things. It's providing a seal so that your air doesn't leak around the sides of the tube. So again, what's our purpose? That the airway must be the only entry and exit of air. So meaning inhalation and exhalation must go through the tube only. We cannot have air leaking around it. So the cuff inflation is necessary. All right. Another reason is, can this patient swallow with that tube in place? No, because look at your epiglottis. That's right here. This is the epiglottis. You're obstructing the epiglottis. It cannot close over the trachea because that's what it does, right? You swallow. Epiglottis moves forward in order to cover the trachea. So the food, whatever you're swallowing, doesn't go into the trachea, right? So therefore, what's the cuff also doing? Preventing what? Because they can't swallow. Can they cough? You can't cough, you can't swallow with this tube. So therefore, can they stop secretions from going down here? No, it's preventing aspiration. Okay, what's the two reasons for the cuff inflation? Seal and preventing aspiration. Okay, now how much do we inflate the balloon by? That's another question. Here's your pressure. Cuff inflation pressure must be between 20 and 25 millimeters of mercury, 24 and 30 centimeters of water. Now, how do we measure that pressure? Not shown here, but the tube, the tip of the tube will have, I mean, you probably noticed that on our mannequins. You see that small little tube coming out with a little balloon at the tip. Okay, so we call that the the pilot balloon. Okay, the pilot balloon is where you will attach a syringe filled with air, and then we inflate the cuff. All right. So if there's air in the pilot balloon, that means the cuff is inflated. If the pilot balloon is flat, that means the cuff is flat. Okay. So that's your indicator that whether or not the cuff is inflated. But of course, the pilot balloon cannot tell you how much pressure is in there. So you have to attach a manometer, a pressure measuring device, onto the pilot balloon and then press the trigger and it will read either. And what do we want the reading to be? Between 20 and 25, what? Millimeters of mercury, or 24 and 30 centimeters of water. Anything below that would mean what? If it's below, okay, there's a leak, meaning the cuff is not inflated enough. What if it's too high? There's too much pressure, meaning too much air inside the cuff. Okay, so what could go wrong with that? So imagine if it is in your mouth. Okay, the pressure should only be between this one. So if the pressure is too high, that means what's the balloon doing, the cup doing in your mouth? It's too much. Is it exerting pressure on the tissues? Is it causing ischemia? There you go. Okay, so here's I know the book says 21 days, but no hospital has a policy of 21 days for an endotracheal tube. Okay, it's only 14 days. Okay. All right, so we said airway placement, verification of placement, airway patency, securing the airway, proper cuff inflation, pressure. And then number 5 is ensuring oxygen therapy. How do you know that our therapy is working? That the patient is properly oxygenated? How would you know that? Patient sedated. Oxygen saturation only? Is that enough? How do you evaluate response to therapy? That's your number 5 responsibility. How do you know it's working or not? What is the most accurate way to evaluate? Because why, okay, ABG, okay? So, because why did we intubate and put them on a ventilator? Because they were in respiratory failure, okay? Or in the case of surgery, because we don't want them, well, dying basically, right? Because they're dead if we don't intubate them, okay? Because of the drugs you gave. You paralyze the guy, so they cannot breathe, okay? But all other cases, you intubated them because were they ventilating or having gas exchange effectively? No, they were in respiratory failure. All right, we'll talk about the complications later. Tracheostomy, you already know how to do trach care and suction. Okay, we tested you on that. Here's your review. How often do we check cuff inflation pressure? Every 6 to 8 hours. Okay. Okay, so this definitely will be a next gen type question, either select all that apply or matrix, next gen type question. Okay. For extubation, this is when you remove. Now, in order to extubate the patient, that means what did the patient meet? Because why did you intubate the patient in the first place? They were in respiratory failure. Now, how do you know they're ready to be extubated? What heck? Do we do this just randomly? Let's do it today. That means how is the patient? Your ABGs are normal. Okay. Are they still in respiratory failure? No more. Okay, the patient's better. In order to do this, we have to do spontaneous breathing trials, SBT. We have to try, is the patient able to breathe on their own? Now you can do that without removing the tube. You simply, one way is, I'll discuss some of these, but does the ventilator have to be on in order for you to do a spontaneous breathing trial? What does spontaneous breathing mean? What you're doing right now. Okay, what we're all doing right now. We are spontaneously breathing. Can you do that with a ventilator pushing air into you? No. So we'll look at the three modes later when we get to the modes and settings. Okay. And then after the intubation, if it's successful, okay, so this is what you monitor. Okay, meaning are they tolerating breathing without the ventilator, without the tube? Okay, so you continuously monitor. If not, we reintubate. Are we clear? Okay. Meaning they went bad again. All right, so here are two endotracheal tubes. One is the standard. Here's the pilot balloon. No, not endotracheal, sorry, tracheostomy tubes. Okay, but that's the only difference here, of course, is the endotracheal tube is long. Okay, so it's about this long. Tracheostomy tubes, about maybe 4 inches long. The one you're looking at here in the B is a double cuffed tube. There's also one that's not a double cuff, but you see like two pilot balloons. But the second one is not really a balloon. It's more like a suction catheter. Okay, because take you back here. Look at the setup. When you put a suction catheter into the tube, what are you suctioning? The tube, correct? Secretions in the tube. But remember, here we call this area here the subglottal area because this is the glottis. That's the epiglottis. So therefore, this area is called the subglottal area. The subglottal area, can secretions pool here? Yes, secretions can pool there. Can the catheter that you put into the tube for suctioning remove subglottal secretions? No, because it's outside the tube, right? So how do you get rid of those subglottal secretions? That's where the high-low, we call that tube that has a second, no, actually a third lumen. And the third lumen are connected here. So there will be some holes here connected to that third lumen. Okay, so still one cuff, but two, or actually three, because this is lumen number 1, lumen number 2 for the balloon or the cuff, and then lumen number 3 will be for those holes here, okay, to allow you to suction subglottal secretions. Can you picture what I'm saying? Okay. So I like those tubes better. Okay. I don't know why they don't make it standard. All right, so we have I explained managing the cuff and how often you check for proper cuff inflation. And the consequences, of course, are mentioned in the textbook as well as on the recorded lecture. So we talked about suctioning and how often, what the indications are. Okay. And here also you'll see the consequences of unnecessary suctioning. Okay. Bronchospasm, not only trauma to the trachea, but you'll also cause dysrhythmias as well. You'll cause SVT, you'll cause some tachycardic dysrhythmias, okay, tachydysrhythmias. Let's go now to the ventilator. Now, the mechanical ventilator, forget the negative pressure ventilators. We don't use them anymore. They're just bulky, inefficient. Okay, so what we have nowadays are positive pressure mechanical ventilators. Okay, what is it? It's a glorified computerized ambu bag. What is it again? Okay, so it beats someone paying someone. Let's say I pay Anuradha. Hey, Anuradha, can you please ventilate this patient? Okay, I'll do it. 50 an hour. So that's all this person will be doing. You pay them to bag the patient. Now, is that efficient? No, because this patient will get tired. This person will get tired, right? They'll have arthritis, okay, doing this. So why not make a machine to ventilate for you? Does that make sense? Okay. So therefore, if this thing fails, what happens to the patient? So what do we do? Manually bag the patient. Okay, so this is what happened when hospitals in the south, let's say, because all storms hit the south, right? I mean, most storms. So they lose power. What do they do with their ventilators? They run out of the generators, run out of juice. So what do? Bag the patients manually. All right. So that's what a mechanical ventilator is. So what equipment should be right there hanging on the mechanical ventilator? An ambu bag. Okay. Ventilator screens can also malfunction. Somebody knocks that thing off with some hard object, screen goes blank. Now what? You don't know what the machine is doing. All right. So therefore, bag them. Remove them from the vent, bag them manually. Are we clear? All right. So they repeated again the indications for intubation and mechanical ventilation right here in this paragraph. Again, forget negative pressure ventilators because we're only using positive pressure ventilators. So what do these positive pressure ventilators do? They push air into the patient's airway, into the patient's lungs, okay, using a artificial airway. Let's talk about settings first, then I'll go to the modes. Here are your settings. Chart 19-5. First setting is the tidal volume. What is the tidal volume? Symbol for this on the ventilator will be capital letter V, small letter T. VT is tidal volume. What is it? It's how much air is pumped into the patient with each breath. What is it again? How much air is the ventilator delivering into the patient's lung? Now, even though that's what you set on the vent, does not mean the patient's lung will receive what the set tidal volume is. Does that make sense? Okay. Because will the lung, let's say the lung is wet, can it receive a high volume of air? No. What if it's dry? Yes. Okay. So this is what we mean. So what I just described to you is compliance. Compliance is an object's ability to expand. What will likely expand? Something dry or something wet? Something dry will expand better rather than something wet. Okay. So for example, and this is the formula they use. Okay. I personally like the height. Okay, the height formula. But your textbook talks about weight. So it's 6 to 10 mLs per kilogram, and that's your tidal volume. Okay. The reason why I don't like it is, let's say, if I'm 250 pounds, okay, I'm only 5'4". Can you imagine what my lungs look like? I'm 5'4", 250 pounds. And then here's Michael Jordan, 6'4", same 250 pounds example. Do we have the same size lungs? No way. Who has larger lungs? Michael Jordan. But with this formula, you're expecting the vent to give me the same tidal volume as Michael Jordan. Does that make any sense? Okay, anyway, that's what your textbook says. So we'll follow this. So average tidal volume for the average person is around 350 to 400. Okay, so let's just use a round number of 400. Next setting is the rate. Sorry? 400 was referring to. We only talked about tidal volume. The average. Average person has a tidal volume of about 400. Okay, all right. Next is the rate. Rate is also called frequency. Well, how many times per minute do you want the ventilator to deliver that tidal volume? You follow so far? Yeah. Okay. Next is we'll get to the mode later because mode is, up here. So we'll finish the settings. The FiO2, sorry, to skip that. So the FiO2 is how much oxygen concentration. So the doctor prescribes that. So it's at least 21%, okay, and it can go up depending on the patient's condition. Peak inspiratory pressure, the doctor also estimates that, depends on the patient's condition. So if the doctor knows that the patient has ARDS, they'll probably decrease the inspiratory pressure. Okay, it really depends on the patient's lung compliance. So let's go back to compliance. So if the patient's lung, do you understand compliance? Do you have an idea? Ability to what? Expand. Okay. So if a patient has decreased lung compliance, what do you think the tidal volume to be set will be? Higher or lower? Low compliance. The lungs have lower or decreased compliance. So how much volume can it accommodate? Lower. How much pressure will be needed in order to deliver that small volume? Higher pressure. Okay, because again, the compliance is very low. That lung is not likely to expand. What if the lung compliance is higher? How much will be your tidal volume? Higher. How much pressure will you set? Lower pressure. Do you follow? All right, so that's the principle of setting on the ventilator. You follow? Okay, let's we'll skip the size setting, okay, because that's not really relevant. Number 6 is sensitivity. Sensitivity is as defined here, so the patient can trigger the ventilator with minimal effort. Now, I'll explain this more later when we get to the mode, because it's hard to explain without understanding the mode. Okay, so just know that sensitivity is a trigger, and the trigger is usually negative 2 millimeters of mercury, or sometimes it can be even a little higher, let's say negative 0.5. Okay, it could be that, or it could be as negative as negative 2. Okay, so what is that? It's like this. So when you breathe, are you inhaling or exhaling? No, what happens first? Okay, so when you inhale, what's the pressure? Negative or positive? You're inhaling. Negative. So what's the pressure? How is that positive? You're inhaling. That's negative pressure. Because what are we? What kind of ventilators are we? We are negative pressure ventilators, okay? Because the positive pressure is outside. It's in the atmosphere. We can't be positive inside because how will that air go in if it's positive? Make sense? So therefore, the human body is a negative pressure ventilator. All right. So that's why we use positive pressure ventilators in order to push the breath into the patient's lungs. All right. So that's sensitivity. Minute volume, this is your part of your charting. We're going to assess minute ventilation. Minute ventilation, the formula is what's your tidal volume and then multiply that by your total number of breaths. So total number of breaths, because there can be, depending on the mode, there's 2 breaths here. Breath coming initiated by the patient, breath delivered by the ventilator. Does that make sense? Meaning there's, depending on the mode. Most modes, though, allow both the patient and the ventilator to initiate the breath. Okay. The 8, 9 are not really settings. Okay. All right. So you understand the basic settings? All right, let's go to the mode now. We'll only discuss 3 modes. Okay, these are the 3 most commonly used modes, okay, for at least for entry-level nurses. Okay. CPAP and BiPAP are modes on the vent. Do you understand what a CPAP machine is? Who does not know what a CPAP means? Who knows what a CPAP means? What is this? Who knows what a CPAP is? Who does not know what a CPAP is? All right. CPAP. This is a machine used usually by sleep apnea patients. So what this machine does is through a mask, the patient will wear a mask, and this machine will blow a steady air, a stream of air into their nose or mouth. The purpose is to keep their airway open because they apparently have sleep apnea wherein their tongue falls backwards and obstructs their airway when they sleep at night. Okay, so blowing the air steadily, make sure there's a steady pressure preventing the tongue from falling backwards and obstructing the airway. Okay, that's a CPAP machine. A BiPAP machine does similar, still blows positive pressure airway. However, positive airway pressure. However, it has 2 pressures. Higher pressure during inhalation, lower pressure during exhalation. That means, can the machine detect whether or not the patient is inhaling or not? Yes. For it to be able to do that, that means there is a sensitivity setting, just like a ventilator. Okay? Meaning, if the machine senses a negative pressure, that means what's the patient doing? Inhaling or exhaling? Inhaling. So it will exert higher or lower pressure? Higher pressure, okay, during inhalation. But if the patient is pushing a positive pressure, that means what are they doing? Exhaling. So what will the machine do? Push at a lower pressure. Okay, so that's what a BiPAP is. Okay. However, that's what these 2 machines can do. They cannot do what a ventilator does, though, because giving a breath is different than pushing air pressure. It's not the same. Both are positive pressures. The ventilator, positive pressure machine, CPAP and BiPAP, both positive pressure machines. However, they're not as sophisticated as the ventilator, where in the ventilator, you can program it to react to the patient, give a breath at a certain interval. Okay, it cannot do that. What does these 2 machines do? Just blow a steady amount of pressure. Okay, what are they blowing, by the way? If it's at home, they're just blowing room air. In the hospital, you can change it. You can change the FiO2 because you can connect an oxygen supply to the hospital BiPAP or CPAP machine. Does that make sense? At home, you can. Okay. Now, these 2 are mentioned here because these are settings on a mechanical ventilator, meaning the ventilator can also function as a CPAP machine or as a BiPAP machine. They're just buttons. You press it, you tell the ventilator, okay, I want you to be a CPAP machine today. Or you set it, okay, I want you to be a BiPAP machine today. You follow? These are what? Settings on a vent, meaning a vent can also function as a CPAP machine or as a BiPAP machine. All right. Why are they available? They're actually there for weaning purposes. Why are they there? For weaning purposes. So for example, right here. So if the patient still has the vent, right? And they still have the airway, the endotracheal or the tracheal tube, whatever the patient has. And then you're trying to wean them off. We're trying to see if we can extubate the patient. Okay. So if I put them on a CPAP and they tolerate it, are they breathing on their own? Okay. Let me back up. Let me try something else. A patient who has a CPAP machine, are they breathing on their own?
Yeah, they just stop breathing at some point.
What about those who are on a BiPAP? Are they breathing on their own? Yes. Okay, because we use CPAP and BiPAP at home, right? So that means those patients must be breathing on their own. In fact, they put it on themselves. So are they breathing? Yeah, they must be. Okay, so again, if I use this on a patient who has a endotracheal tube on a ventilator, then I'm trying to see if they're ready to be weaned. I turn off the vent mode, I put it on a CPAP mode. That means, is the patient breathing on their own or not? Yes, the answer is yes. Are we okay now? All right. So you can see why this is a weaning mode, yeah? Because you're turning off the vent mode. You're trying to see, is the patient able to breathe on their own without the vent giving them any breaths? Because if you turn it into a CPAP machine, what's the machine doing now? Just simply giving a steady pressure of air, right? That's it. So that's one way to wean a patient. Okay, so the modes we'll discuss today are only three. They are AC, also known as assist control, and there's also CINV, which is continuous intermittent mandatory ventilation. I don't know why the author removed the continuous, but it's supposed to be called CIMV, okay, not IMV. CIMV is also the same as, no, sorry. SIMV is called synchronized intermittent mandatory, okay? So AC and CIMV is the same. I'll explain why later. And then finally, PSV. PSV stands for pressure support ventilation. Okay. Three only. So we'll do assist control or CIMV is the same. Okay. Then number two is SIMV. Third is PSV. All right. Now, before I discuss the three, let me discuss controlled ventilation. Controlled is figure A. See figure A here? Okay. Controlled ventilation. We're not testing this. I'm just trying to, I'll explain this first. That way you can appreciate AC, SIMV, and PSV. Okay. So what determines the mode? The mode is determined by the patient's need. What is the patient's condition? Are they in respiratory failure? Are they in ARDS? Or let's say they are in surgery. Okay. So remember, one of the indications for intubation and mechanical ventilation was someone going to surgery, correct? especially general anesthesia. So let's say Peter is undergoing heart transplant. So he'll be intubated, put on a ventilator. So in order to stop him from moving around during surgery, because can he twitch and allowed to scratch something while he's under surgery? No. So we're gonna give him, besides general anesthesia, we're gonna give him neuromuscular blocking agents. Okay, so succinylcholine that will paralyze him, including his diaphragm. Okay, so is his diaphragm working at all? No, that's why we intubated the guy and put him on a ventilator. What mode will be used? The control mode, because his diaphragm is useless. It's not moving at all because of the drugs we gave him. So the only mode that will work for him is the control mode. What is the control mode? It's 100% vent control, meaning the ventilator will give him a set number of breaths at a set number of frequency per minute. That's it. What will the ventilator do under control mode? A definite set number of breaths with a set tidal volume. Okay. Can Peter do anything? No, he cannot. The vent will do all the breathing for him. Why? Why can't he do anything? He's paralyzed. Okay. Now, imagine a scenario other than a paralyzed patient that a control mode will work. Can I put you right now, each of you, on a control mode and expect you to be comfortable? What will you do if someone is giving you breath when they want, as often as they want? Exactly. It will never work for any other patient. Do you understand? This will never work. So you will only see this where? In the OR, or someone who's sedated, who's paralyzed, undergoing major surgery. Are we clear? All right. So you understand control, right? Do you want it? Can you think of any other patient that's not under surgery who likes this? No, this will never work. Okay, so let's go now to CIMV. No, assist control or continuous mandatory ventilation. CMV-AC. Okay, what does this mean? In CMV, this is a volume mode, by the way. There is a preset tidal volume. There's also a preset rate. What's preset? Tidal volume and the rate. Okay. Meaning, is there a minimum number of breaths that the ventilator will give? Correct. Is there a set tidal volume? Yes. So if it's the ventilator giving the breath, it will give the preset tidal volume, which is, let's say, 400, and it will give it at the minimum number of times or frequency that it was told to do so. So let's say the patient is on assist control or CMV, and the preset rate is 12, and the tidal volume is 400. So the patient will receive what? How many breaths? 12 at how much each time? 400. Okay. A feature of this is, that's why it's called assist control, is it will allow spontaneous breaths from the patient. Meaning, yes, the patient will receive 12. Whether the patient wants to breathe or not, they will receive 12. So if it's set at 12, every how many seconds will they expect to receive a breath per minute? It's just a computer. So every minute they will get 12. So every how many seconds will that happen? Yeah, 12 per minute. Every minute. So every how many seconds will the vent give the breath? 60 seconds divided by 12 equals 5. So every 5 seconds, the patient will expect to receive a breath. How much each time? 400 tidal volume, 400 ml. What if the patient wants to take a breath? Can they take a breath? Absolutely. However, that's the only thing the patient can control, the number of breaths. They can add a breath, but they cannot control the tidal volume. Right here. Here's the explanation. In CMV or AC, the ventilator delivers preset tidal volume, preset rate of respirations. Yeah? If the patient initiates a breath between the patient's breath, the ventilator delivers the preset tidal volume, preset pressure. So therefore, can the patient control the tidal volume? No. If the patient initiates a breath, which they're allowed, so now how does the ventilator do? I mean, how does the ventilator know the patient was trying to take a breath? What setting allows that? The sensitivity. Remember the -2 millimeter or -0.5? Okay, whatever is the trigger or the sensitivity, that's the ventilator's cue. So if the vent senses a negative pressure, what's the meaning of that? What's the patient trying to do? Initiate a breath. So what will the ventilator do under the AC mode? Let's say the patient triggers the breath. So what will the vent do? What will the vent do?
It won't stop.
Yeah, but so what will the vent do?
Reduce pressure.
So here, so if the patient initiates a breath between the ventilator breath, meaning every 5 seconds, the patient receives a breath from the vent, right? What if they initiate one between those breaths? What will the vent do? If the patient initiates a breath between the machine's breath, what will the vent do? The vent will deliver a preset tidal volume. So how much will the patient receive? The 400 that was preset. Any question about this mode? Does it sound comfortable though? Here, let me show it, okay? So let's say this is the 5th second. What will the machine do? Give a breath. Okay. I receive it, 400 ml. 5 seconds later, I get another one. Okay? By the way, the vent will not suck air out during exhalation, okay? The vent will simply not deliver anything. The patient will exhale passively, okay? It's passive. What if, let's say this is second number 5, and then 3 seconds later, I initiated the breath. I tried, and then what will the vent do? Deliver 400 ml over 1 second. But before I could completely exhale, like this, imagine this. So this is the 3rd second, okay? I'm supposed to get another one 2 seconds later, but I initiated one on the 3rd second after the last one. So it's like this. I did not complete the exhalation yet from the last breath, but now I received another one, okay? Because the timing was wrong. And imagine just do what I just did. And then do that. Everybody do that. And tell me how you feel. You felt lightheaded, yeah?
Yeah.
Because what happened? Why did you feel lightheaded? What happened to your cardiac output?
Yeah.
It went down because the intrathoracic pressure increased. There's too much volume of air in your lungs. So what are they doing to the heart in the middle? They're squeezing the heart. So that's why what happened to cardiac output during that moment? Cardiac output dropped. So the patient felt lightheaded. So imagine the patient who was sedated, who's under this mode, who is obviously when the patient takes more breaths, are they getting better or worse? No. They're under AC, right? So let's say they were in respiratory failure. You intubated them. So the first mode most likely used is AC. Okay, this is the most frequently used mode. Almost everybody will be on AC, except those who are in ARDS, they will be on a different mode. But most respiratory failure patients will start in AC, okay, assist control. Now, if they're taking more and more breaths every minute, that means are they getting better or worse? Actually, they're getting better, right? So therefore, what will be the result if the patient now has, because the machine will give 12, whether or not the patient breathes. If the patient breathes 12 of their own, will the machine cut back on the 12 that they was told to give?
No.
No. The vent was told, you told the vent to give 12 every minute under AC mode. That's what you put there, 12. You dialed in 12 breaths every minute. No conditions. But the patient is now taking more of their own breaths here. And what will the machine do? Every time the patient initiates their own breath, it will deliver the preset tidal volume. So now, vent is giving 12, you told it to. Patient is now taking 12 of their own. So what's the result?
You get it more oxygen.
Well, the total ventilation is now 24 per minute. What do you call that? Well, not necessarily. Is 24 breaths per minute normal?
No.
What do you call that? That's hyperventilation. And what will be the ABG result for someone who's hyperventilating? Patient will be in respiratory alkalosis. So when you draw ABG, what will it show? Respiratory alkalosis. Is that good? So what's the solution for that scenario? Is this mode appropriate? No, this is not the appropriate mode for this patient. Patient's now breathing more. We can't continue using AC or CMV. Now we move to the SIMV. Right, so what does the SIMV do? It's still a volume mode, so therefore every volume mode has a preset tidal volume, preset rate. What's in every volume mode? Preset tidal volume, preset rate. Still, let's say 400 each time, but this thing has a lower rate. So instead of 12, this is around 6 or 8 per minute. Is 6 enough breaths per minute? No, but why did we put the patient on this mode? Because the patient is breathing more. So therefore, the AC mode is no longer appropriate. Okay, the patient is getting better. Now, SIMV can be a main vent mode, or it can also be a weaning mode. You understand? This can also be used as a weaning mode. When used as a weaning mode, you can drop the rate as low as 2. You can drop it to 2. Okay? So if the rate is 6 to 8 or as low as 2, can you put a patient in respiratory failure on this mode?
No.
No. So this mode is only for which type of patients? Either weaning or are they bad or better?
They're better.
The patients are better. Okay. So think of SIMV as they're not ready for extubation yet, but they still need, they still need a little help. Okay. So can we expect what type of mode, therefore, do you expect people who are on chronic vents to be on? AC or SIMV? AC is the one we just talked about earlier. Patients who are on, long-term care facilities at home, who are on ventilators with a tracheostomy, what mode are they on? Those people are on SIMV, okay, with a lower rate setting. You understand? Okay. You know why? Correct. They are They are breathing on their own. They just need a little support, okay? Obviously, they can't be breathing on room air, okay? They still need, because they need a ventilator, okay? Meaning these are patients who are, let's say, after a stroke, right? So they had, depending really on the type of stroke, let's say it affected the brainstem, obviously those patients will be on a vent, okay? They'll have a trach. I mean, there's no way they can sustain normal respiratory rates, okay? So what's in SIMV? If it's the same as AC, which is a vent mode, I mean a volume mode, this thing has a preset rate, has a preset tidal volume. Here's the difference. Between ventilator delivered breaths, the patient can breathe spontaneously with no assistance from the ventilator on those extra breaths. Can you read it again? See if you understand. Elisa?
No assistance from the ventilator.
Very good. Okay. So what does this mean? So let's say the rate is at 8. 400 tidal volume, 8 frequency. So every how many seconds will the patient get a breath from the vent? If they're getting 8 per minute, 60 divided by 8. About every 6 seconds and change, right? Okay. So let's say 6 point what? 6.2. Yeah, 6.2 seconds. Yeah. Okay.
So 60 divided by 8.
Yeah, 60 seconds divided by 8 breaths.
7.5 breaths. 7.5 breaths. 60 divided by 8.
Oh, 60. Oh, I was thinking 50. Okay. So 60, yeah, 7. So about 7.5. Okay. So every 7.5 seconds, the patient will get a breath from the vent. Okay. 400 each time. If the patient decides to breathe, let's say 3 or 4 seconds after that 7 seconds, what will happen? What will the vent do? Vent will do nothing. Patient can breathe on their own. The patient can determine how much the tidal volume will be. So the patient may breathe in 300 ml, or the patient may breathe 600 ml. Okay, because it's their breath, they determine their own tidal volume. Are we clear? So which one is more comfortable? SIMV, but only for what type of patient? A spontaneously breathing patient, okay? A better patient. A very bad patient in respiratory failure, what's the proper mode for those guys? AC or CMV. What about for better patients? SIMV. Chronic patients on tracheostomies? SIMV. Okay. Last mode, PSV. Unlike the previous two, this is not a volume mode. It's called pressure support ventilation. So therefore, this is a pressure ventilator. This is a pressure mode. What will happen here? Since it's a pressure mode, there is no preset tidal volume. There is no preset rate. The only thing preset is pressure. Again, no tidal volume preset, no rate preset. So what is this ventilator mode doing then? It's only delivering what? Pressure, just like a CPAP, just like a BiPAP. So what type of patients can be safely put on a PSV mode? It does not give a breath. There is no tidal volume. So what type of patient can safely be placed on PSV? Who is breathing spontaneously. So therefore, this is purely a weaning mode. You cannot put a sick patient on this thing, on this mode. Only for weaning. This is an exclusively weaning mode. Are we sure? Are we following? Okay. So what are the three we discussed today? AC, SIMV, and PSV. Okay. We did mention control mode, but that won't be on the test. I only said we only discussed control. That way you understand how is it used and then what the ventilator actually does. Okay. Problems, these are discussed in the recording. So that's on table 19-5. There are two alarms that will be tested. We have high pressure alarm and low pressure alarm. Let me go back to the figure on airway. Remember the picture of the artificial airway? So if I have an artificial airway inside me and I'm attached to a ventilator, is there some resistance that my lungs will pose against the ventilator? Yes or no? Yes, because my lungs, are there holes in my lungs? No. So therefore, can the ventilator just indiscriminately blow air into my lungs without rupturing it? No. There will be resistance, correct? Okay. So what do you think will trigger a high pressure alarm? High pressure alarm is triggered by there's increased resistance. Yes, there is resistance normally between the vent and my lungs, of course. That's why one of the settings was peak inspiratory pressure, correct? So the doctor dials that in. So therefore, if that peak inspiratory pressure is met, meaning or exceeded, it will trigger a high or low pressure alarm. High pressure alarm. Now, what type of problems could potentially trigger a high pressure alarm? So this is me, I'm the patient. There's a hose, I have a airway, a hose, a circuit tubing, two of them going to the ventilator, one to the oxygen supply, one from the vent. So what can cause a high pressure alarm between me and the vent? High pressure. If I stop breathing, what type of pressure alarm will it trigger? High or low? That would be low pressure because now the vent's trying to push air. It's meeting no resistance at all. So the patient must be, patient stopped breathing. So let's stick with the high pressure first. So high pressure alarm, what else will trigger that? What if I'm fighting with the vent? Yeah, that will trigger high pressure alarm. What if there's a kink in the tubing? What if there's so many secretions in the tubing? What if there's so many secretions in my airway? Okay, so increased peak airway pressure, that's equivalent to high pressure alarm. This is table 19-5. So the following can trigger a high pressure alarm: coughing, plugged airway, decreased lung compliance, tubing is kinked. What about a pneumothorax? Yes. Or my lungs collapse or bronchospasm, meaning a patient's coughing, something like that. Okay. What about decrease in pressure or low pressure alarm? What can trigger that? One is increased compliance, so it's not always bad, or there's a leak somewhere. Okay. Or what if the patient woke up and then pulled the endotracheal tube? Now the tube is on their lap. There's no resistance at all, correct? Okay. Or there's a leak in the circuit. Okay, somebody cut it. Okay. Or the patient, but by the way, the circuit is only attached like this to the tubing. There's no lock. Okay, you just like that. Doesn't even, this is better. See, it locks. You heard that? There's nothing like that on the vent. You just slip it on like this. That's it. All right, there's no lock. That's a safety feature. Okay, so we need to disconnect the patient. We should be able to take it off like that. Okay, there's no lock. Are we clear? So that happens if the patient is on a trach. Let's say they're, looking for attention. Let's say they're calling and you don't want to go into the room because it's something silly. Okay, what they'll do is they'll pull it, trigger the alarm. Now you'll have to come in. Aha, now you come in, huh? Yeah, they'll do that. They'll take it off. Don't worry, they won't die. But the machine will go crazy because the low pressure alarm is triggered. Okay, and you can't ignore it. There's no way to silence or mute that alarm. It will go. Okay, it won't stop. And it by the way, it registers the alarm, how long the alarm was. So if we do quality control, they'll look at the log. Why was this alarm going off for 5 freaking minutes? Okay, so and they'll trace who was working on this vent on this particular time. Then they'll see, oh, Alana, come here. Okay. Can you tell us about this particular day, this time? What was happening? The ventilator was crazy for 5 minutes. What were you doing? Okay. There's no what if. Okay. You have to deal with it. Okay. So you'll have to deal with that patient. Yeah. Yeah, they do that. Okay. There are some patients and they'll use that too. If they hate you, but what will protect you? No, what? Documentation. Document what happened. Okay. Each time it happens, document it. Remember, it's your license. Okay. Patients can get you in trouble. All right. Okay. That's why I like patients who are unconscious, that don't talk. I like those better. Okay. Like septic patients, when they come in, blood pressure is very low, they're lethargic, won't do anything. I like those. But when they get better, then the attitudes come out. Okay. I mean, I'm happy they're better, but yeah. So in my mind, like you were so much better when you were lethargic. But at least you did a good job. Okay. So now they're better, but you just need to get them out of there as soon as you can. All right. Okay. So here are some more problems. Cardiovascular compromise. By the way, I forgot to mention this. It's normal for the patient blood pressure. No, sorry. Scratch normal. It's not the correct term. Expect some patients to have hemodynamic instability after intubation. Okay, so once you intubate the patient, let's say you intubated them for something else, for respiratory failure, right? Because they were septic or whatever, but they were stable before you intubated them. I mean, blood pressure wise. they can go hypotensive. Okay, we call that post-intubation hypotension. It's a real phenomenon because of cardiovascular compromise. Because what's happening now that we're not on a vent, right? So what type of ventilators are we? We are negative pressure ventilators. Now we changed that from a few seconds ago to now, from negative to positive pressure ventilation 20 seconds later. I say 20 seconds because that's the average time for rapid sequence intubation. Okay, I forgot to mention that. So when we intubate nowadays, this is the 21st century. Let me describe first what we did before. So 30 years ago, this is how we intubated patients in respiratory failure, right? So they're like this, having very bad, respiratory distress. What we did was hold this patient down, 5, 6 of us holding this patient down, someone at the head, open the mouth, insert that laryngoscope, put that tube in, and then hope the patient is, the 5 of us can overpower this patient. Okay. So if the staff we picked were like puny ones, the small little nurses, students, somebody's gonna get kicked, somebody's gonna bleed, okay? Somebody's gonna lose their teeth because this patient will hit and kick and scream, okay? Because they're confused to begin with, and then here you are shoving that cold tube down the throat, okay? So of course they'll fight, okay? They're already confused. They have low oxygen already. Nowadays, we use rapid sequence intubation, very peaceful. First, we sedate the patient. Rocuronium, small dose, 2-minute half-life. That's all we need. Just 2 minutes of silence. Put that tube. The patient is paralyzed. Don't worry, the diaphragm's paralyzed, but we're putting them on an mechanical ventilator anyway. And it's only for how long? 2 minutes, okay? Maybe 1 minute. So the patient's paralyzed, very peaceful. Tilt that head, insert the laryngoscope, put the tube in, voila. 20 seconds later, they're on the vent. All right. So we do RSI now. Nobody gets hurt. Patient's fine. Staff are fine. Okay. So that instant switch, of course, changes the pressures inside. So we go from normal pressure to now high intrathoracic pressure because of the vent. Now the body can't adjust to that readily. So the cardiac output drops. Okay. So expect to put the patient on a vasopressor. All right. For those, probably for a few hours, maybe 24 hours at the most, and then they'll be fine. Okay. Unless the patient was septic and you know why, right? Why blood pressure drops with sepsis. Okay. So unless that's the case, but patient wasn't septic, and then you wonder, why is this patient now unstable after we intubated them? They weren't on pressors before. Why are they on pressors now? That's because of post intubation. Okay. But that's short term. Then the heart will eventually, get over it and then adjust. Barotrauma, again, this is because of positive pressure breaths, that these alveoli are not used to positive pressure. Our alveoli are supposed to be used to negative pressure. Now you're forcing air. Some of them will pop. Okay, you'll fracture some of them, and then you'll have pneumothorax or even barotrauma. Infection, this is ventilator-associated pneumonia, usually starts 48 hours after intubation. So we can't, actually we can prevent it, but not 100%. So this is your interventions, septic technique, frequent mouth care. There's a chart for, probably not a chart, it's probably in the paragraph. Okay, how to, we call it the VAP bundle, ventilator associated pneumonia bundle. I can't find it, but it's in the recording. Let me just enumerate them.
What bundle?
VAP. Okay, so the VAP bundle is One, you suction the airway. How often? As needed, and use aseptic technique. Head of the bed must be 30 to 45 degrees. You have to give them PPIs. Okay. If you're asking why, what does that have anything to do with the pneumonia? Well, the secretions, because this is caused by secretions, obviously, right? If the secretions are less acidic, which is what a PPI will do, correct? Increase pH, so it's not very acidic. So when they do aspirate, it doesn't cause acute lung injury as bad. Okay. Number four is there has to be anticoagulation, DVT prophylaxis. They saw a connection between DVT and ventilator associated pneumonia. I don't have the study, but that's part of the bundle. Number five is it's here. Proper cuff inflation pressure. Okay. That's part of the VAP bundle. There's probably one or two more. Um, uh, what? Chart 19-6. Right here. Chart 19-6. So here's the PPI, peptic ulcer disease prophylaxis, DVT prophylaxis, head of the bed elevation 30 to 45. Although they didn't put the proper cuff inflation pressure here, but you understand why it's part, right? Because if your cuff inflation is under inflated, what will happen to secretions? It'll go straight down into the lungs, causing pneumonia. Okay, so it should be part of that too. But at least if they do aspirate, which they do, there's no 100% guarantee that these patients won't aspirate. They will. However, if the secretions are clean, will it likely cause pneumonia? No. Because what does your breath smell like in the morning? Do these patients brush their teeth? No, they depend on you. Plus, can they close their mouth? No, the tube is there. They can't close their mouth. So all sorts of organisms can enter that mouth. So you have to provide mouth care. Frequency. Well, I do mine every two, during turns. Okay. If you turn every two, you should do oral rinses every two. It's okay for us 3 times a day because, we close our mouth, but these patients can't. Okay. Although I think the frequency mentioned here is daily, but I mean, do you agree with daily? No. Yeah, here, see? Daily. Okay. The daily here, I would to defend this bullet with chlorhexidine. Okay, so chlorhexidine is an antiseptic, right? So yeah, maybe once daily, but oral care should be every two. Okay, should be every 2 hours. For chest trauma, okay, I won't repeat what's on the recording. For chest trauma, please focus on signs and symptoms and management. That's it. Signs and symptoms and management. Let me see. Yeah, same chapter. So for each one, especially the difference between rib fractures and flail chests, it's not the same. These two are not the same. Okay, so rib fracture is different from flail chests.
Yes.
Right. Yeah, in flail chests, well, of course, all of them. But when you think about chest trauma, it's very rare that the patient only has one. For instance, a contusion, pulmonary contusion, right? What does that mean? What does a pulmonary contusion mean? Okay, how did that lung, which is protected by ribs, pleura, ribs, muscle, and skin, get injured? You can't easily get to that, right? How did that lung get bruised? That means what else did they have? Did they have only one chest trauma?
No.
No. There's always multiple. All right? Do you understand? So you'll never deal with one chest trauma. There are several injuries because again, think about it. How did that lung get injured? It's protected, right? You have so many layers of tissue protecting that thing. So how did it get injured? That means the patient suffered multiple chest trauma, meaning in order to get to that lung, let's say a pneumothorax, right? Of course, this is chest trauma. We're not talking about pneumothorax from spontaneous pneumothorax because that caused by COPD, etc. But when we say traumatic pneumothorax, so now how did that patient get that traumatic pneumothorax? That means either an object penetrated it or it could be the patient's own ribs that were broken and punctured that pleura or that lung. All right? Okay. You still remember cardiac tamponade from pericarditis? Okay, so cardiac tamponade can also result from chest trauma. Okay, it may not only puncture the lung, but also puncture the pericardium. Also, in what's this? Heart surgery. Okay, so when you have any thoracotomy, any no surgery involving the heart, when you cut open the pericardium, is that still trauma? Yes. So you still need to drain that, correct? With the same, well, smaller test tubes, of course, and same box, same chest drainage systems. Okay. So what do you need to study for each chest trauma? Signs and symptoms and okay, because are these emergencies? Yes, so you need to recognize and be able to intervene. You should know what to do. Some of them will just simply say, call the doctor because you can't do surgery. Okay, but you need to initiate it. So therefore, you can't initiate if you're not knowledgeable about what's going on. Okay, you see these signs and symptoms. I don't know what that is, and then you don't call the doctor because you don't know what it is. So therefore, you recognize it, then you'll know what to do. Okay, either call the doctor or do something else before calling the doctor. Right. So just follow signs and symptoms, and then what do you do? What are your actions? All right, we'll finish up with liver disorders next week.